You're listening to My Favorite Show, where Dr. Richard Call and Greg Riccardi discuss the matters that matter most. Join the conversation by calling 800-962-1160. And now, Dr. Call and Greg Riccardi of My Favorite Show.
Okay, Greg Riccardi here. I'm your host of My Favorite Show, sitting right next to my co-host, Dr. Richard Call. How are you doing, Doctor?
Very well, thank you, Greg. But and it's good to have you back after your little scare tactic last week when you were one step away from the pearly gates.
I wish it was a scare tactic. It was definitely a scare, but I don't know about a scare tactic. Yes, it was a very interesting week, I have to say, and
sobering.
Very sobering. Very sobering. Before we begin, though, we want to remind everyone that we have a website associated with our show. It's MyFavoriteShow.com, and we encourage and urge you to call in with your questions. Number's 800-962-1160, and you could text them in as well. If you text MFS to 313131, and then put your name and the question, whatever you want to let us know, you can certainly do that as well. So, yeah.
And good. And before you began, being a physician, I just wanted to make sure that we took all precautions. So I have an ambulance waiting downstairs.
Standing by.
And I have cardiac resuscitation outside. And luckily for you, today in the office, in the studio, we have two doctors. So if anything should occur, don't count on us.
That's what I figured, actually. Yeah. So, anyway, folks, yes, it was a very scary week this week. Last Monday, prior to the taping of My Favorite Show with Dr. Call here solo, I felt a little chest pain, and then it turned into a lot of chest pain.
Was that after listening to me?
That was when I thought about you. Actually, I'm like I have to call Dr. Call, and then it just hit me. But suffice it to say that, I actually did have a bona fide heart attack, actually. Yeah. I'm 46 years old, and if anything good comes out of this, which a lot of good, already has, but definitely would advise anyone and everyone out there to get checked. Now I have had high cholesterol for a long time. I've known that for a long time. And you take the medication and things like that to keep it down, but there's nothing really to tell how much blockage there is without a stress test. And the interesting thing, I'm not going to say funny thing, but the interesting thing was that I had a stress test scheduled for Tuesday, the next day, and my doctor is part of the Valley Medical Group, and Dr. Wiederman, and he had, they had called him when I was on my way to the hospital, and said, "Hey, Greg Riccardi's here," and this was Monday, and he was saying, "No, he's supposed to come tomorrow," and they're like, "No, he's here today with a heart attack." And he's like, "Oh my God," So he obviously came down, to the hospital, but somebody else did the procedure. Everything went great. I had a stent put in one. I had 100% blockage in one artery, right, and then 70% in another.
Wow.
So, let me
ask you something. People who experience these, I wouldn't quite call it a near-death experience, but kind of like in that range. They have all visions. They have these visions of them floating above their body and seeing teams working on their bodies, and then they're given the choice of you can go back to a life on Earth and debts and bills and dealing with collect calls and this kind of stuff, or you can float off to heaven.
Right.
Did that happen to you?
No.
Oh, okay. And had it done so, what would you have chosen?
Well, most of them you don't hear the choice being given to them. It's like you have more to do. You're going back. Or what's that? Yeah. I if I had the choice, I would have obviously opted
come back for more.
To come back, exactly, because
fool.
We have more shows to do, right?
Oh, that's right.
So no,
well, you wouldn't have to be. I could do the thing they did with Michael Jackson, the Mirage, the Holocaust,
right?
Where you could create use a hologram,
right?
To have you sitting there.
Yes.
Yeah.
That would have been kind of cool. No, but speaking of that, like, if you want to say near-death experience, I was very calm.
Peaceful.
The whole time.
Yeah.
I mean, purposely. Like, well, purposely, but it wasn't hard to do. I just knew that I had to keep myself very calm.
Yeah.
Keep my heart rate down, not freak out. And it was actually a very, like, Zen-like time the whole time. Because I, when they first came to my house, I was by myself. And I had felt this pain. And when I did, I lay down on the ground, face down. We have these pillows in our living room where we kind of watch TV and stuff. So I lay on the pillows. I felt better that way. And then, thank God, I had my cell phone in my hand. And it was charged. I mean, there's so many little things that could have happened that may have prevented me from getting the help I needed as quickly as I did.
So, all those little points on your life, the details, if you turn left outside of a room as opposed to right, how it can change your life. I always am fascinated by that, how those moments, literally like a second, sometimes not even a second, can change the course of your life. And, you just happened that morning, I suppose, to think about, having the cell phone charged and making sure it was charged and,
Yeah, I mean, I felt like I was just sick. I mean, we had Easter the day before, and I thought maybe it was something I ate or something, So anyway, I had the phone in my hand. I laid down, and I forget where I was actually going now because you interrupted me. But I'll tell you anyway.
You're going to get a hamburger and chips.
I went to get a hamburger and chips. No, but I got myself help, thankfully, so quickly that there's basically no damage to my heart. So they cleared the one blockage. I have to go back to have the other one cleared. They put stents in. But thankfully, big picture,
everything worked out fine. So let me ask you, you've been brought back here by the good Lord. He's given you a second chance, after your, the first part of your life. He's like, I'm going to give you a second chance.
Right.
I mean, so why do you think now that you're back here and you've had a taste of, maybe the other side or not quite the other side, has it changed you in terms of?
It has. This week has been very surreal, obviously. I mean, I can't even believe what happened. And it took me probably till Thursday or Friday last week to actually have it sink in that I had a heart attack.
Right.
And since then, I have felt in a big sense, very, very real sense, and I hope this lasts, that it's almost like I don't care. Not in a negative way, but I don't care in terms of...
You've become fearless.
I think I've become...
You become fearless. I know exactly what you're talking about. That... we've discussed this before.
Yeah.
We've discussed this before.
Yeah.
There's an incredible liberation of the spirit. I call it the gift of death. It's a kind of an oddity of an expression. But, what it does, if it happens to someone very close to you or nearly to you, is that it really does emancipate your spirit. So after that, there's really nothing that you're going to be afraid of. Nothing.
Right.
Yeah, it's true.
Yeah. I mean, that's basically what it is. And different but related, I feel like everything is brand new.
Right.
Everything is brand new. It's almost like I shouldn't be here right now, in a sense. And everything's alive. Everything is it's like I'm watching a movie. Like right now, you guys are sitting here, and we got the.
And if this were a movie, I would,
it would be a scary movie.
It would be a scary movie, right? Yeah.
Or one of those depressing,
Bête noirs.
From what I'm looking at now, bête noir. But no, I really feel like, this is. It obviously, wasn't my time and stuff, but there's so many things that I just normally stressed about. They say that
it's a fascinating. What the comment you made was a fascinating comment. It wasn't your time. People say that. Oh, it wasn't my time. And I always ask, well, hold on, who's holding the clock? Like, where's the clock?
Someone is.
Is it this argue of destiny or fate, or do we have a role in how long that clock goes on? Or do we just think we have a role in it, and it really is just set?
Well, a good friend of mine, her name is Ann. She says that And she firmly believes that, it's when it's your time, no matter how you got, left this
It's
earth.
kind of a circular argument, right? Because when people do die, that's what people will say, it was his time, without really knowing that it was his time in any other way other than the fact that he died. So you say it's his time.
Well,
because there's no other evidence to support that, in fact, it was his time.
Well, that's easy to say when, it is a heart attack or it's in a car accident or something like that. But, the only times that doesn't really, not that it doesn't apply, but it's hard for me to apply that feeling or thinking is when, someone gets killed or something where it's like.
But you can still say it was his time.
You can.
Yeah.
Oh, no, certainly. Yeah. But
I'm so glad that you're back, Greg. Because I did feel, first of all, I felt very lonely not having you here. Your chair was much more comfortable than mine, but I'm glad to be in the bad chair again. Keeps me on my toes.
Yeah.
And, I'm sure your family were thrilled to see you back in action, chasing the dogs and looking after the kids.
Yeah. It's amazing. I'm, with my kids and I'm hugging them and just being regular guy with them, dad. And it has completely new meaning right now. You have kids, right?
Yeah, I have a kid, and I actually had a similar experience about 2 years ago.
Did you really?
And I spent about 3 weeks in an ICU. And being emancipated, as Rich said, it changes you. And Rich and I have spoken, obviously, outside of the studio together. It gives you a different appreciation for life. Mm-hmm. And you appreciate every minute, every second of every minute with the people you love.
And I completely broke rule number 1 of radio. I just asked somebody a question who we didn't formally introduce into our...
well, that's okay. He's the mystery man until we do formally introduce him.
He's the mystery man. Actually,
people will be guessing.
That's Dr. Doug Spiel, right?
Spiel. Spiel.
Someone says, give me the spiel, you always have it.
I'll give you whatever you ask for.
There you go.
Well, awesome. Listen, I did want to bring up the fact that, we're entering now the political mad season. You know that, right?
We are.
We are entering the beginning of the political mad season.
Correct.
And, everyone is throwing their hat, towel, shoes, pants, skirts into, what do they call it, the ring? The ring. Announcing that they are going to be entering their candidacy for the nomination of whichever party they belong to.
That's true.
I think there should be a third party in this country. This two-party thing, I think, is done.
Mm-hmm. Well, that music is the signal. We have to go to break right now, but we're going to pick up on that conversation right on the other side. Stay tuned for some commercial announcements. Got to pay the bills, as they say. And we'll see you right after the break.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
Take a look under your bed. Find stuff under there? What about jobs? No? Now try your basement. There's a pair of overalls that overall you're not so into anymore. A perfectly good laptop that hasn't seen your lap in months. And even more stuff. But still no jobs? Well, you really have both. See, stuff is defined as household articles considered as a group. Sometimes this stuff is no longer needed. Wait, no longer needed? That can't be right. Because remember those jobs you were looking for? Those are really needed. And they're the stuff inside your stuff. Even inside that winter coat that moved with you to Phoenix. Our job is to unlock those jobs. And it starts when you donate your stuff to your local Goodwill. Here's how we do it. When you donate to Goodwill, we sell your stuff to provide job training for people right here in your community. So just by teaming up with Goodwill, you help create jobs. And isn't that worth parting with the leftover keytar from your 80s cover band? Goodwill. Donate stuff, create jobs. Find your nearest donation center at goodwill.org. A message from Goodwill and the Ad Council.
And we're back with My Favorite Show. I'm Greg Riccardi here with my co-host, Dr. Richard Call. Say hello.
Hello.
We did that already. And we remind you that we'd love to hear from you. Give us a call, 800-962-1160. Love to hear your questions. And before the break, we were talking about the whole political thing going on here.
Yeah. We're talking about I call it the political mad season. And I'm fascinated and at times repulsed by politicians. I've often wondered what type of person would choose to go into politics, but all kinds do for different reasons. And in the United States, they have their elections nationally every 4 years. And they've got the national elections coming up in 2016. And so all the candidates are announcing their candidacies now. And we've got Hillary Clinton, who did it yesterday, did it very quietly, unlike the previous time. We've had, I think, Ted Cruz, who's announced his intention to run for the Republican nomination. There's also been, I think, Scott Walker. And I don't think Chris Christie has, as of yet, announced his decision to run in this race. So he's leaving it quite late. But it's on the Republican side. I think it's going to be an interesting race to see who gets that nomination. It's a pity, in my opinion, that Mitt Romney pulled out. But on the Democratic side, other than Hillary, I really do not see any other contenders. So if it comes down to Hillary and the bunch they've got on the Republican side at the moment, I have a feeling that Hillary's going to win.
Yeah. Okay. Now, we are here. You had said that our country needs a third political party. Don't we have the Independent Party, or is that's not?
No, you need a substantial third political party. In England, they have the Conservatives, the Labour, and the Liberal parties. Mm-hmm. And in most European countries, they have 3, if not 4, political parties. The two-party system is intrinsically fraught with problems of conspiracy and corruption. And I think one of the issues in America that I always found coming from the UK strange was how much money was involved in running a political campaign. And I could never quite understand why it was. I thought that a political campaign should be run on the strength of the arguments. Mm-hmm. And whether or not you had 1 million or 100 million, it should make no difference. And I think what's happened is that political campaigners have spent all their time trying to raise monies to go out and spend on adverts and TV commercials, etc., and lost point of what it is they're arguing for. And in my opinion, if you go back to the true politicians, you go to the ancient Greeks,
right,
when they were standing in their auditoriums arguing to the people, let's do this, let's do that. These guys were simple guys standing in robes and sandals.
Right.
They didn't need all this money. So I think there needs to be election reform. There needs to be a limit on the amount of money. Mm-hmm. So my suggestion to this is this money should come from the taxpayers' fund. Right? There should be a specific amount that's allotted to each party at election season. And that's all they've got. That's it. No going out to super PACs, no going out to PAC funds, no going out to special interest groups. That's wrong. Right. Because they're perverting the political process. And in doing so, they're doing a disservice to the American people. It's not right. So I think it should be limited as to how much money they get.
Makes sense. Now, in the UK, is there they don't have campaigning money and commercials and things like that? Or
no. There's a fund. There's a political fund that is allotted specifically to the parties when they run political campaigns, and it gets around this issue of not all corruption, but it gets around this issue of political corruption and political influence. And there were a number of scandals many years ago in the British Parliament where they called the case, cash for favours. It was the same thing. It was people, lobbies, with lots of money going to the members of Parliament saying, we'd like you to bring this question up at question time, and we're going to give you lots of money. They got rid of that. And in a true democracy, right, a true democracy where it's the people that decide on the arguments, money should not play a factor. It should not. Right. And I think in America, it's gotten out of control. I think you've got too many of these big super PAC funds putting in money. And the thing that a lot of Americans don't know, Greg, is that a lot of this money comes in from other countries. It's not American money. It's Chinese money. It's Russian money. It's Indian money. It's African money.
Really?
Yeah. So you've got other countries dictating how your political process is going to go because they understand the benefit that's going to incur to them should Party A be elected or Party B.
Right. Dr. Spiel, what's your take on this? Do you have one?
Well, for years, growing up as a physician, you kind of lend yourself towards Republican sort of a bend. And it's difficult for all of us not to vote our pocketbook. And that's pretty much, I think, what's lent itself into the political arena, if you will, right now, is that many of these politicians and they go play to their pocketbooks. And that's where you get the super PACs monies and the similar funding. I think it's an interesting concept to have an equal amount of money in each pot and have them go out and just debate the factors and not have to play to this public interest group or another.
Right.
It may even the playing field, but you've got a long way to come to get there.
Yeah, I agree, Doug, and I think it's going to take some political muscle. But I think the muscle that's going to do it has to come from the people, because this is a country, America's a country, right, that was founded by the people, for the people. You know, it wasn't founded by monarchs. It wasn't founded by men wanting to replicate the British monarchy.
Right.
So this is a country of citizens that have this power and have this say. So, the irony sometimes that I see in it is that it's a country that was formed to get away from the tyranny of King George and the monarchy. But in many ways, what's happened, if you think about it, they're not wearing wigs and gowns and the rest of it.
We're right back
There are monarchies hanging out in the White House.
Gotcha. Now, I know you guys want to talk about this political doctor.
You mean the spine turf wars?
The spine turf. Did you coin that phrase?
I did.
The spine
turf. And what do you think of that? That's a brilliant piece of marketing, right?
That's
the
good.
spine turf wars. You see, here's the thing. I'm a great student of history. Now, the Second World War was only called the Second World War because some guy said, listen, we have to give a name to this period of time. We can't just say there were like lots of battles. We're going to call it the Second World War, and we're going to give it a time period. So I said, we're going to call this the spine turf wars, and we're going to give it a time period. And that's what we did.
There we go.
Well, there's a lot of turf wars going on right now.
Okay.
So I think Rich is basically pointing towards the turf wars going on with physicians.
Yeah.
Whereas physicians of different backgrounds are battling for procedures on the same playing field. But it's not just going on with physicians. It's going on with companies that produce all the little doohickeys that we use. And 7 different companies can have 7 different doohickeys. And they go to the masses and they go to all the physicians and say, we want you to use our piece. So there's a lot of battles going on right now. Specifically in medicine, many of us trained in different backgrounds. I know Rich was an anesthesiologist. I was a radiologist about 15 years ago, and we both started performing endoscopic spine surgery. Different skill sets that brought us there, but we both learned many of the key points in order to surgerize patients and do it both safely and efficiently. And certain associations have opened their doors to us. The American Society of Interventional Pain Physicians produced the American Board of Interventional Pain Physicians that allows people of different backgrounds still to get board certified and go on to learn those types of procedures. So the gray areas between the disciplines are blanching now with time. Certainly every subset of physician population wants to hold on to whatever procedures were inherently theirs. But the idea of what was inherently ours is now changing.
Correct. Technology does that.
Right. So is this so that you can keep performing the same type of surgery you've been all this time? And so does it boil down to a money thing?
Well, money's a part of it, okay?
Right.
Of course, money plays a part in every aspect of our lives. There's no
Right.
getting away from that. However, it's more than that. It's an issue of professional ego, professional jealousy, professional protectionism, and what happens and what has happened in the spine turf wars, which people should go and read. There's a book now, published on Amazon. What they should do, when people read the book, they'll see that there was this sudden evolution of technology in spine. There was an improvement in imaging techniques so that people could see what was happening in the spine. And the guys who came from interventional radiology, like Doug, and interventional pain, like myself, we had these skills very well developed. So we were able to use this portable X-ray machine called a fluoroscopic C-arm and visualize the spine and put probes, needles, instruments, and dissectors into and around the spine quickly, safely, and effectively, much more so than a traditionally trained neurosurgeon or an orthopedic surgeon who did not receive training in fluoroscopic guidance and interpretation, which is the key component of this. And the example that I always use is look at cardiology. 25 years ago, when most people had a cardiac issue like yourself, Greg,
Yeah.
they would go into hospital and they would have their chest cut open and they would have a bypass done by a cardiac surgeon. Today, if they need anything done, they have an interventional cardiologist place a little tube and place a stent. Well, that's what we do. That's exactly what we do on patients, and we get them in and out the same day. The neurosurgeons don't like it because it takes away their business. Now they're going to have to retrain. And some of them are. They're realizing that this is the way of the future. The orthopedic guys are going to have to retrain. Some of them are, because they realize this is the way of the future. But ultimately, all of this is better for patients. And, once you've started a good thing, it's not going to stop. And I happened to be involved in a very high-profile public battle about these particular types of cases. But guess what? 10 years later, these outpatient minimally invasive fusions are the standard of care. Mm-hmm. Progress.
Well, we have a website, One Day Fusion, where I share it with actually an orthopedic surgeon friend of mine, and we can put minimally invasively fusion apparatus into the lumbar spine. And aside from the pedicle screws, which I know you're very familiar with, little rods and screws in the back of the spine, placing the cage is done through an 8.5 millimeter cannula. And so with the addition of...
That's the tube, right?
Little straw.
Right.
So with the addition of that little cage and some screws in the back, and the advent of what we have now is a type of anesthetic that'll last days and not hours, liposomal bupivacaine, we can really get these people out of the hospital within 24 hours.
Which is exactly what I was doing 10 years ago. Now, I'm not going to, there's no one here to pat myself on the back, so I'm going to pat myself, right? But I was and Doug is my witness here, I was the first doctor ever to perform an outpatient, minimally invasive spinal fusion. It was considered a combination of insane, revolutionary, groundbreaking, but it changed the face of medicine. Mm-hmm. And today, this is what is happening. And this sector, the minimally invasive spine sector, specifically the outpatient minimally invasive spine sector, is predicted for an enormous growth. So, things have changed. The way that we treat people's back problems have changed.
Right.
For the better. Right. Nobody wants to have their back sliced from neck to sacrum. Nobody wants that. Okay.
Right.
And doctors like myself and Doug have the ability and the training and the expertise to do these cases. And, there are just going to be some guys who just are never going to accept that, but it's a fact of life.
All right. So when we get back from break, I want to ask you about, is the war subsiding, I guess, because you're saying this is groundbreaking, this is now prevalent in terms of the new way of spine surgery. And, we'll go that direction. So, again, folks, Greg Riccardi, we'll see you in a few minutes. Thank you.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
My name is Meera Batra. I have been in this country 32 years, and this is how I live united. America has always been the land of promise, and in my community, many families have come for a better life. Coming from another culture myself, I know the desire to become part of a community, to feel at home, and to gain the tools for our children and families to succeed. So I advocate for these families with United Way. United Way empowers them to look beyond their histories and to see what opportunities are available. We help them get involved with their kids' schools, network within the community, and when we do, we unite them. We make the community stronger. What I do is something I wish someone had done for me, and I am so grateful I am able to. My name is Meera Batra. I help families see opportunities and succeed. I don't just wear the shirt, I live it.
Give, advocate, volunteer, live united. Go to liveunited.org. Brought to you by United Way and the Ad Council.
And we're back with My Favorite Show. Greg Riccardi here with my co-host, Dr. Richard Call.
Good evening.
And our special guest here, Dr. Doug Spiel. Before the break, we were talking about the spine turf wars. And my question is, what's going on with, are the wars still, big and prevalent?
I can say, and I'm sure Doug will agree and he'll have his own opinion, I can say that as a consequence of the the high-profile nature and the fireworks that went off surrounding my case, that things have settled down a little bit. Because I think the realizations amongst the people who didn't quite understand the arena have settled in. That technology has changed. That people are getting better by having procedures done in a minimally invasive fashion. There are still, however, some what I would call sectogenarians of the medical community who don't quite understand, what's going on.
Right.
But they're going to be gone soon. So I think we've come through, I would say, the worst of it. And, looking at things globally, I can tell you that, I've been contacted by many groups of physicians from around the world asking for me to go out to their parts of the world and train them in these techniques. And I think it's been, for me, it's been a very heartwarming and reassuring thing to hear and to have and to be able to be a part of. To know that, I was part of a group of guys in New Jersey that changed the face of spine medicine, because it wasn't just me, it was Doug, a couple of other guys who really were at the forefront of changing medicine for the better, and to provide better care for patients.
Greg, some of the procedures we do, there are analogous, similar, minimally open procedures that can be offered to patients. Certainly in a low back, we do a lot of endoscopic spine work, and there are forms of microdiscectomy that are relatively smaller incisions. Certain of the procedures that we do, there are no analogous open procedures. When we do endoscopic spine work in the cervical spine and the neck, we're making very small incisions, 5 or 6 millimeters, and we can remove just the herniated portion of the disc and leave the remaining disc in situ without affecting it. There is no analogous procedure open. They have to take out the entire disc and do a full fusion, known as an anterior cervical discectomy and fusion, whereas endoscopically, you go home with one suture, one stitch, and maybe some glue, and you go home the same day.
Wow. So what's your typical case? Is it an injury, or is it just old age? What brings people to you typically?
It's mostly degenerative. Like 90 to 95% is degenerative, and within that we include patients or people who've been involved in car accidents. Who've had an acceleration of their degeneration. The majority of cases we treat are in the cervical, the neck, and the lumbar region.
You see, I don't like the term degenerative because I think degenerative presumes that we knew that there was no insult and time took effect. I think in many cases, many of these people, I feel, had some kind of an inciting injury that led to this.
Yeah, Doug's right. Yeah.
At some prior time,
which they may or may not have been aware of.
I would agree with that, Rich.
Yeah. Right, gotcha. So, and age-wise, you see them all over the place, or?
I've operated on teenagers and men and women in their 70s, near 80.
Mm-hmm.
Yeah, it's and people ask that question about age. Pain does not discriminate age. People experience pain in their 20s and in their 80s.
Right.
And that's essentially what we're treating. So as physicians in this sector, people come in and they say, I have pain. Then what then our responsibility is to use our diagnostic tools, our eyes, hands, and our physical examination skills in conjunction with MRIs, CAT scans, X-rays, nerve conduction tests to work out where exactly the pain is coming from, to map the pain. Once we've, spotted where the issue is, we then use our skills in minimally invasive spine surgery to go in and to treat that part of the problem. And we do it specifically, and we do it safely, and we do it without the disruption of all of the muscles around the back, which is what the old-timers used to do.
Right. So, speaking of that machine you talked about, the C-arm?
C-arm.
Right?
Yeah.
That's what they used with me as well.
Correct. It's a fluoroscopic C-arm. It's a mobile X-ray unit.
Right.
And it's one of the key components of this arena, not just in spine, but in cardiology, because what it does is it allows visualization of body structures that have been injected with contrast or bony structures, and it allows the individual physician or surgeon to perform the procedure in real time to know where the catheter probe instrument is going and where it needs to go. And Doug's training, Doug's an interventional radiologist, so he's the real expert on this.
Right.
Well, you know what it allows us to do? It allows us to see things in two planes because it rotates. So what orthogonal views allow you to see, you get to see left and right and front and back. So in a three-dimensional mind, you can take two-dimensional views and figure out in terms of where you are exactly. Because you want to operate on the area of pathology.
Right. So just to give people at home in their cars, a visual of this, it literally is like a C, a big C, right? And the bed that you're lying on is in the middle of the top and the bottom of the C, so to speak, right?
Correct. Yeah.
And that rotates circularly. And could you say it's like a line? I mean,
I guess the opening of the C, there's a unit on the C that sends the electrons, and one of the units that sees the electrons. Mm-hmm. And so if the opening of the C was on the side of the left patient, you can rotate it 90 degrees so that now you're looking at from the sides of the patient. Right. So up and down or side to side. And those two dimensions are very important because that lets you locate a specific point in a three-dimensional world.
Mm-hmm. Mm-hmm. Yeah, so then while you're actually in the operation, in fact, I even saw it while they were putting the stent into the artery. You're actually, it's almost like you're watching TV. You're not
it's like watching a video game.
Right,
yeah,
right.
correct.
Now, by the way, that was a radiology procedure years ago before the cardiologist took that.
What's the difference between a radiology procedure and a...
Well, a lot of the procedures that are carried out using fluoroscopic guidance started with interventional radiologists. And the funny thing in spine is that the neurosurgeons and some of the orthopedic guys tried to hijack that and claim it as theirs, when a lot of these approaches were developed by interventional radiologists. Mm-hmm. So, that's kind of the hijacking, the sort of the turf war bit that goes on. But at the end of the day, what it really comes down to is the proof of the pudding in the eating, right? So you look essentially at who's doing the best job for the patients and who are getting better.
It's interesting that it kind of seems like, not being in the medical world, kind of seems like you guys are in your own world doing this kind of fighting and positioning and stuff, but most people, wouldn't know about it.
That's why we're talking about it on the radio.
Well, the patients don't know.
Right.
And with all due respect, when you walk into a doctor's office, you see a couple of diplomas. Hopefully he greets you and has a nice word for you when you come in, and you feel comfortable when he sits down or she sits down with you and tries to explain the procedures. The level of expertise is very difficult to share with a patient and to get them to know what you do for a living.
Right.
And quite honestly, when they look in their handbook of doctors, my Blue Cross handbook and Blue Cross Blue Shield says there are 6 doctors in this area that are listed. You're not listed.
I'd like to make a point that I've made before, actually, on one of the early shows, Greg, about something that Doug is just bringing up. There are doctors and there are doctors. And just as there are artists and artists, some people have a greater innate ability to perform procedures than others.
How do you, as a patient, figure that out?
It's impossible to figure out at first consult. And this is the point that I made before. The best way to know that is word of mouth, a referral from somebody who has had the procedure done. That's the best way to do it.
Okay. And how, if you have something that's you've never had before, how do you find someone who has? Well, I've had a cold before. I can ask my friend, "Hey, I know you've had a cold. What do you do for it?"
More and more, we're seeing a lot of stuff on the web now.
Mm-hmm. Yeah.
So we're seeing testimonials on the web. We're seeing blogs. We're seeing everything sort of viral. It's a new age. And as a physician, I'm trying to now embrace that new age. And certainly, we weren't taught that in medical school. We're trying to grow with the times.
Yeah.
And it's important. There's no greater honor that can be paid to you than having one of your patients or even a doctor or nurse that you've operated next to send you someone from their family. And those things, no greater honor. And it's a terrific feeling, by the same token, to go in and treat somebody and get them feeling better a week later and say, wow, my pain is gone. So I think we're trying to broaden ourselves to the viral web because that's the new age.
Yeah, people, Doug is absolutely right. The first place that anybody goes today for anything about anyone or any subject is the internet. And they'll go on and they'll put in the correct Google terms and, a whole lot of information will come up. But even within that digital content, what Doug has just said is correct. If you've got other patients or other doctors talking about the work that a physician performs, they are the best advocates for the patient.
I know that there's these magazines, at least in the Bergen County area, where they've got best of the best, best of Bergen County, stuff like that. I don't even mention magazines.
Those are tough. Those are really.
Well, I mean, listen.
Those are supposed. In fact, I know a market research company. It's actually, I'll say what, Leftline and Associates, good friend of mine, Bobby Leftline, and they do these tests or these surveys where they will send out the letter or a form to doctors within a certain category, whether it's a dentist or this, a surgeon or whatever, and they'll say, vote for your peers in terms of who you would, recommend.
Okay, but hold on a second.
Yeah.
Okay. Yeah. I'm going to say this. Right? I'm going to be, bold. Right? I'm going to be bold about this. Those things are a joke, and I'll tell you why.
Okay.
I'll tell you why.
Why?
Okay, because sending out a form to all these guys and saying vote for so and so. Okay.
Right.
Most of those guys have never been in the operating room with the guy who's doing the procedure, right? They know him socially. They know him to go out. He's a good guy. Yeah, we go bowling. Those are the kinds of things. Their sense of who the person is. What you want people who have had the procedure by these doctors to vote. They're the relevant votees, not the physicians.
Well, I mean, I'm just kind of saying it's based on what you just said a second ago, Doug, where doctors refer other doctors, and that's how you know when someone is.
Well, some of us don't fit in any of those catchment groups. So I don't know of any radiologist that'll vote me a radiologist that does endoscopic spine surgery. And similar to that, I'm pretty sure that no orthopedic spine surgeons are going to vote for me in their group.
That's why I'm saying that whole thing is a joke. It's an old boys club coming together, voting their friends in. It means nothing, right? To go to the issue of how do you find a good doctor who can do the procedure well, like Dr. Spiel, it comes down to patience.
Mm-hmm.
Like, somebody who's had the procedure done and has done well. That's what you're looking at. And, for example, I don't know the exact numbers that Dr. Spiel has performed over the years, but I'm sure they're into the thousands. And if you look at his statistics, his outcomes, his complications, I'm sure they're excellent. Those are the types of things you want to look at. Those are the numbers, the data, the hard data that will tell you if a guy is good, bad, or should be sent to Cuba.
Well, now that the door's open to Cuba, you're probably not doing him a disservice by saying.
Well, they sent over theirs, right, in the 1980s on the Mariel boat lift.
Excellent. Well, listen, on the other side of the break, which we're going to have in a second, you brought some toys with you.
I did.
That you're going to have to, folks, you're going to have to look at the website, MyFavoriteShow.com, to see what Dr. Spiel brought with him. And we're going to go to commercial break. We'll see you in a few minutes.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
What if your brother
or your husband
or your daughter?
What if your son came back from the service with a spinal cord injury?
A quadriplegic.
A paraplegic. In a wheelchair.
When they volunteer to serve, we expect our country to be there for them if they are injured.
For more than 60 years, Paralyzed Veterans of America has been fighting to ensure that we receive all of the benefits that we've earned.
Benefits to help with medical care, rehabilitation, and training. And our dedicated professionals know how to navigate the system, so our injured veterans can concentrate on getting well.
Thank you, Paralyzed Veterans, for helping our daughter.
My husband.
My son.
Thank you, Paralyzed Veterans of America, for helping my brother.
To learn how you can help our injured veterans, visit Paralyzed Veterans of America at pva.org. A public service of Paralyzed Veterans of America.
And we're back with My Favorite Show, sitting here with myself, Greg Riccardi, Dr. Richard Call, and our special guest, Dr. Doug Spiel. Am I saying that right?
I think you said it great.
Oh, good. Because, people misspell or missay Spiel. They say Spiel. And I mean, not in terms of a name, but when they're talking about,
But you've got a great radio voice.
Do I?
Yeah,
Oh.
yeah, you've got a great radio voice.
Thanks.
But listen, let's cut straight to the chase here, because I know that there's so much we got to cover.
That's right.
And I wanted to get back to the business or the calling of medicine, and the speciality that Doug is involved in, which is mine. And he's been working diligently on finding techniques and ways of treating pain syndromes that were otherwise difficult to get to. So, for example, somebody who has what's called a pelvic pain syndrome, so the lower abdomen, pelvic region, it's difficult to really know sometimes what's causing that and how to treat it. And, what we used to do in the past was sometimes just do one-off injections and put some medicine in and hope for the best, and the medicine would dilute away and the patient really wouldn't be any better. But what Doug has done, which is, I think, a brilliant idea, is come up with a intelligent catheter that is threaded under fluoroscopic guidance into the affected region of the plexus, so the nerves that innervate that area and are involved in the pain process and are involved in the generation of a syndrome that we call complex regional pain syndrome. He has invented and come up with a catheter that can go in, through which you can have a long-term injection of antalgesic agents that will minimize the level of pain. So, saying that, I'd like Doug to talk a little bit about this.
Rich, you said that very well. So, as we interventionalists look at the spine and in the nerves around the spine, there's two major things we have to decide upon. Number one, is there an anatomic basis for the pain? Is there something that's hurt that we can fix? And frequently there is. There's a herniated disc, there's pressure on a nerve, there's a broken foot that we cast. The second problem is there a neuropathic aspect to your pain. Is for some reason the nervous system, which should be in homeostasis, not functioning normally. And so there's some form of upregulation. And in many of these pain syndromes, what we're seeing is the insults that originally occurred and caused the pain have become far remote instances. And what we're left with is a nervous system that's essentially painful, where pain is the problem. Pain is protective. If you're an animal and you slice your foot, you shouldn't run on that foot. And the pain has a protective effect on the body. After a while, if your pain is simply due to abnormality in the nervous system, that should be quiesced. We should quiet it. And as Rich aptly said, there's a number of ways to do this, to do so. One of the ways is we can do repeated blocks, and we stick needles in portions of the body, and we introduce an anesthetic or a numbing agent to try to turn off the nerve. And there are sequential type blocks that we do in many instances. The key problem is that it takes a certain amount of time to make benefit of the neuroplasticity of the nervous system. The nervous system can be reset. And what I mean by that is just because your radio is running at a 9 or a 10, there's a way to turn down the volume switch. And in much the same way, we can turn down the volume switch of your nervous system. Many of the things that we have in many of these peripheral syndromes used to be known as RSD, reflex sympathetic dystrophy,
right.
complex regional pain syndrome. And when I looked at the pelvis and complex chronic pelvic pain, I see it as an analogous situation as we see with arms and legs of people who have RSD. And so I said, why can't I shut down the nervous system there? Now, about 20 million Americans, mostly women, have chronic pelvic pain. And it starts out with interstitial cystitis, problems with the bladder, endometriosis, pelvic inflammatory disease. All in all, approximately 1 out of 7 women, which is a huge number.
Yeah.
1 out of 7 women between 18 and 50 have chronic pelvic pain. They have pain that lasts at least 2 weeks out of every month for 6 months. It's a tremendous amount of people. And what I found was that some sequential blocks over time can turn down the pain. Why not create a catheter which, when placed and attached to a reservoir, which is an area that holds a bunch of medicine, and then a pump, why can't we just infuse the medicine over 7 to 10 days, turn the pain off, and then remove the catheter?
Yep.
The reason we couldn't do that before is the catheters move. And why it's important is when you're putting a medicine on a nerve, you want to put it right on the nerve.
Right.
It's not a hand grenade.
Yeah.
If it's in the room next door, it doesn't work.
Mm-hmm.
So what I created was essentially a tined catheter, which looks very much like an arrow. And when you pull out the stylet, which is the inside portion of the catheter, you're left with a rather rubbery device with tines on it.
Right.
With the end of the catheter, it's basically externalized or brought outside the patient, attached to a pump. Medicine is infused, and we can turn the pain off for a period of 7 to 10 days, which takes effect and utilizes the benefit of neuroplasticity, wherein we turn down the nervous system. Now, this catheter should be available to me within the next month. It's going to be known as the IntelliCath, and we're doing our final testings this month with it.
So what do the tines do?
The tines resist motion so that if you try to move, they keep the peripheral or distal portion of the catheter adjacent to the nerve in question. It's spring wound, so the catheter itself can actually be formed into a knot, and still the inner portion of the catheter will conduct fluid.
Wow. So now how does it work? So basically you put this in and then you leave it and you kind of,
comes out of the body.
Administer and you put the medicine in the
The
tube.
medicine goes into the tubing, and over a period of time it drips for a few cc's an hour for every day. The bag will hold a couple of hundred cc's. So in about 3 days or so, you come back, we change the bag, you go back out. In 7 to 10 days, we pull the catheter. There are other utilities for this catheter. Even men.
So this is something you invented?
Yeah, I have 50% of the patent, and the trademark is IntelliCath. And we hope to start using these in people within the next month or so.
That's great.
So it's been what kind of approval process do you have to go through?
So we're undergoing what's known as an engineering change order, an ECO. It's predicated upon a catheter that's already FDA approved. The tines itself are made out of the same polymer that the catheter is made out of and has been approved for indwelling catheters seen in the intrathecal aspects and epidural aspects previously. So all we're changing is really the tines on the catheter.
Gotcha. Oh, so you just it's basically what it was, but you added the tines.
Yeah, the simplest mousetrap is predicated on an original mousetrap.
It's kind of like the thing you buy at the store when your sink is your drain is clogged, and you stick it down, you pull it back out.
So it resists. Then after a couple of pounds of pressure, it'll pull out.
See this? I took a $1 billion idea and I reduced it to like a drain opener. So now. All right, cool. So this is something you invented. It's about to go into use.
We'll follow my algorithms for it. Essentially, patients will come in, whether they're women or men. They have vulvodynia. They're unable to put in tampons, unable to have sexual intercourse. The pain is tremendous. They'll come in. We'd like them to be cleared by a urologist or gynecologist so that we know that they have benign disease. Can we treat people who've been treated for cancer? Absolutely. But we want to make sure they don't have that when they come in. They'll be triaged and evaluated. They'll undergo a physical examination, a history. And if they're a good candidate, we'll do an initial block. If the initial block is effective for a period of hours or days, then we'll schedule them and we'll put a catheter in. They'll walk around for 7 to 10 days, drop back in about 3 times over that period of time. And hopefully at the end of about 10 days or so, they should have significant reduction in their pain, which may be permanent or may just go away for a long period of time.
Gotcha. So, I mean, I come from, I don't know what you want to call it, the world of, I guess if you can say it that way, the thinking of that the body and, takes care of itself type of thing. And if there's a problem, there's a reason for the problem, right? So what would you say to someone who, feels like, well, instead of, like, if you're just killing the pain, are you not solving whatever problem is causing the pain?
Let me just say something about that, Greg. That's actually
a great perspective.
No, it's not a great perspective.
Well, it's terrible perspective.
It's actually an incorrect way of looking at the process of disease and pain. People incorrectly assume that pain is a symptom of disease. which it is to an extent. However, it is a disease in and of itself, that causes and leads to symptomatic changes in the cardiorespiratory system, the metabolic system, the neurological system. So pain has to be treated. If it's not treated, and you follow the body fixes itself dictum.
Not fixes itself, but
it corrects itself. However,
no, not even. I mean, just saying there's a what do you call it? I don't know, like a sense or
an old wives' tale.
No, no, but not that it fixes itself, but that the pain is being caused by something.
Can
I hold on? Let me tell you. I don't like to take cold medicine, right? Because I've subscribed to the thinking that a disease is the cure, meaning my body's trying to get something out of its system.
That's the kind of
and by
thinking,
taking medicine, I'm stuffing whatever it is back in.
No, that's the kind of unscientific thinking that got people into a lot of trouble in the 11th century.
Mm-hmm.
When an injury occurs in a body, there is pain. Pain occurs for several reasons. One, it's protective, so it allows the body to respond in a protective way. However, pain that goes from being acute to becoming subchronic or chronic is itself an entity that's very negative for the development and the maintenance of human health. So that pain has to be treated. And what Doug's describing in terms of pelvic pain, that's a chronic pain that's unrelenting, unremitting. And what happens to women who are suffering from this type of pelvic pain, they start to go insane.
Gotcha. Well, listen, we started a thing. I wanted to have a big fight with you, but it's the end of the show. Can you believe that? It just went like that. So anyway, if you want to contact Dr. Spiel, why don't you give us, how do you do that?
The office is 732-548-2000. The main office is 1921 Oak Tree Road in Edison, New Jersey. Or you can see us on the web at www.spielmd.com.
Fantastic. Again, I'm Greg Riccardi here with Dr. Call, wrapping up this issue of My Favorite Show.
Thank you, folks. Thanks for listening.
You've been listening to My Favorite Show, where Dr. Richard Call and Greg Riccardi discuss the matters that matter most. My Favorite Show is taped live Monday nights at 7 p.m. To watch the video of this broadcast in the WVNJ studio, visit MyFavoriteShow.com.